morning. Hope you're all doing good. Guys, today we have the OMR series on a very important case, which is a mitral stenosis. Hope you're all liking, subscribing, and sharing these OMR series. These are basically help you to understand how to go about and what errors you can afford to do and what you shouldn't be doing. Definitely people who are going to give your exams in February, remember you are already there, but couple of things which you need to work around is practicing this, because finally the OSCEs are all about what you speak in those 10 minutes. Okay. So remember, your real strength comes from being your best you. So you already are good. Just have that confidence in you and make sure that you do whatever possible in the time given, and that's all is required. Okay, so let me keep the timer, and we are going to do a short case on structured discussion on mitral stenosis, which has been frequently asked. So that's the reason I wanted to make sure we cover this task. Okay, I have Aisha with me. Hi, Aisha.
Hi, Sowmya.
Hi. Thank you so much for joining again. And so she will be my examiner for the case. So yes, we shall start with the time on. Yes. Okay. Hello, I'm Sowmya, one of the exam candidates. I've gone through the scenario and I'm happy to start the discussion.
Hello, Sowmya. How are you doing today?
Yeah, all good. Thank you so much.
Yeah, can you summarize the case for me?
Yes, here I have a high-risk pregnancy, which is a mitral stenosis, a primary gravida with a known case of mitral stenosis at her 16 weeks. Definitely, I would want to know further about the details because this is a high-risk pregnancy.
Yeah. So what information do you want to gather from her?
Yeah. So the first thing which I want to know about is her cardiac disease. So for the mitral stenosis, actually, how was it diagnosed, whether it is congenital or whether it is rheumatic heart disease? If rheumatic heart disease, whether she's on still on penicillin prophylaxis, I would want to know. And I would want to know with whom she is following up, whether she is following up with a cardiologist, especially now she's pregnant. I would want to know whether she's in whether she's in touch with the multidisciplinary team. And when was the last investigations, which is most important, echo has been done, and what medication she's on, because of the complications like atrial fibrillations, whether she's on any particular medications, I would want to know, and also the folic acid, what she's taking on, and whether any recent admissions are the flare-up of the condition, I would definitely want to know. So because I can counsel her regarding the same. So apart from that, I would also want to know about obstetric history, because she's 16 weeks, whether she has got any blood tests done and the scans, how it has been done, and if most important, whether she's symptomatic now, what's her NYHA classification status now, because again, that can help me to understand and guide her properly. And also about her obstetric history, as I was trying to tell, I could see she's a primary gravida, but I would want to know a bit in detail about that. And also I would want to know about her family history, if it's congenital, if anybody else in the family is affected, and whether she has any other comorbidities which can affect her pregnancy as well, and any other surgeries in the past, and whether she has undergone any surgeries like valvotomy, because this is known to be recurrent. So whether she has undergone any valvotomies or the valve replacement, I would want to know. And also any particular allergies, because I want to prescribe her the safe medications, and habits, particularly alcohol, drugs, and smoking, because that could have a general impact on the overall pregnancy, and the support at home. Because for these, I would want to know with whom she's living and how is the support at home, because that can help us to guide her better. And yeah, those are the main things which I would want to know from her.
Okay, so your patient, Angeline, it's a case of congenital mitral stenosis, and it's a mild mitral stenosis, and all her tests that has been done so far has been normal, and she's on regular MDT care, and her last visit was 2 weeks before.
Okay.
So I just want you to tell me what is NYHA classification.
Okay, this is a New York Heart Association classification, which helps us to identify the severity of the heart disease they have got. So obviously the class 1, NYHA class 1 is completely asymptomatic. Class 2 is where they do a severe exertion, where only they become symptomatic on the severe exertion. So that is slightly compromised. And the class 3 is somebody when they do even the mild exertion if they are having the problems. And class 4 is somebody at rest. So even at rest, they are feeling orthopnea, dyspnea, all those things. So that is how the NYHA classification would be done.
Okay, now can you take me through her antenatal care?
Sure. So now, as I understand that this is, even though she's asymptomatic, I would be really wanting to have a closer look on her, because the woman with a mitral stenosis can become, their condition can deteriorate as the pregnancy goes on because of the load, the cardiac load which the pregnant woman will have. So, and they are mostly the condition tends to worsen in the second, third trimester and immediately after the delivery as well. So as she's already on the MDT care, definitely we need to continue the same, and she will be having a frequent visits also. And I would be counseling her on effect of pregnancy and the mitral stenosis and vice versa. So basically, we will be vigilant for particular things like avoiding tachycardia, because if there is a tachycardia, then there is the diastolic filling doesn't happen, and she's at a more risk of the worsening complication like the pulmonary edema. So we have to avoid things like hyperemesis. Obviously, she has crossed 16 weeks, anxiety, pain, stress, those things we need to avoid. And if she is having tachycardia, it has to be treated early with the beta blockers. And if we have to be vigilant for the development of the pulmonary edema. So if she develops pulmonary edema, obviously we need to be making sure that she gets admitted, and the diuretics, that protocol we will follow, and atrial fibrillation. So once the tachycardia set in, we have to think of the atrial fibrillation. So how we are going to do is we would be in constantly touch with the consultant obstetrician and the cardiologist. We would work as a team, and we would be having the frequent echo based on the cardiologist advice. And as well, we will be making sure that her VT risk is assessed at every visit when she's coming in. And for the baby, we need to be making sure that because this is congenital MS, there is always a possibility of fetal congenital heart disease, which is around 3 to 5%. So now she's 16 weeks, so 18 weeks, along with the fetal anomaly scan, we need to be doing a fetal echo as well. And definitely, if you find a findings according to that, we can counsel. And the baby will be at a high risk of having a preterm labor. So we need to tell her the signs and symptoms, when she has to come in. And the baby could be at a risk of IUGR. So frequent monitoring based on the individual risk we would be doing on. And apart from that, we need to make sure that if she has any other risk factors for the development of preeclampsia, we need to be very vigilant as well. And also, like at 32 weeks, we need to be putting in touch with the anesthetist, because labor analgesia and labor care plan is very important for them to be done. So that also we would be doing as an antenatal care plan. And obviously, we would advise her to deliver in the consultant-led care unit.
Okay, how do you plan her delivery?
Okay, definitely we will have a clear-cut MDT care plan for the delivery as well, and it would be documented in the note. So whoever is involved in our care will be aware. And once she gets admitted, she needs to have IV access, full blood count, cross-matching should be done and kept, and continuous CTG for the baby to be done. And epidural analgesia, we will discuss with the anesthetist. Epidural analgesia could work out the best, probably because the pain can actually affect her like tachycardia, and we can reduce the risk of pulmonary edema. Very, very, very important. One is avoiding tachycardia. With the pain and anxiety, we have to be taking care. Second thing, she has to be on a dry side, because if we push the fluid a lot, then she can go into pulmonary edema. So we need to be having a proper intensive monitoring of the fluid chart. Hourly, there will be fluid chart, and hourly review should be there. And as well, fourth hourly senior review should be there. And ECG pulse oximetry should be continuously be monitored. However, pulse oximeter should be the value should be assessed by a trained staff, because sometimes there could be differences in that. And the next thing we would be knowing is the cardiac output monitoring, which should be managed by either it could be non-invasive monitoring or the fetal echo. So the cardiologist is the best bet to answer for that. And then if the labor progresses normally, if her NYHA class allows, she can go as the normal progress, but we need to be making sure that cut short the second stage of labor if she's exhausted or if the baby has issues. And cesarean section could be recommended for class 3 and class 4 if she's symptomatic. Obviously, active management of third stage of labor to be done, but we need to make sure that low infusion oxytocin would be given and avoiding ergometrin. And consultant obstetrician should be present throughout, and the neonatologist will be taking care of the baby once she delivers. And so, and obviously, we will be making sure that she's not dehydrated, at the same time maintaining the balance, because VTE is something which we need to look into these cases.
Okay, so how do you manage her postpartum?
Yes, postpartum care is again, there are two important things. One is the risk of cardiac load on her, and the second thing would be the VT risk assessment. So again, the cardiologist's opinion is important. And if you have started on beta blockers for avoiding the tachycardia, we need to look into whether we need to continue or not. And about the breastfeeding, if she wishes, she can go on unless she is severely compromised like stage 4. And obviously the contraception and the VT risk assessment and the normal postpartum care like bladder emptying and then making her mobilized and looking at her VT risk, all those things would be done. And yes, sorry, I forgot to mention need for antibiotic prophylaxis. We need to be looking from the time she gets admitted, because we want to avoid infective endocarditis. That is something we need to do. And if it is started, we need to continue the same as well in the postpartum. And also, we need to think of the contraception before she goes. If it is a normal cardiac function, all the contraceptives can be given except CHC, that is class 2. If it is abnormal, definitely CHCs are not recommended, and all others becomes class 2 and UKMA category 2. Obviously, it depends on all other conditions. And if she has complications, we need to talk accordingly. And we need to definitely tell her about contraception and spacing the pregnancies before she leaves, and providing information leaflets and the GP letter. So that's the main thing which we'll be doing in the postpartum.
Okay. Do you want to add anything else?
No, thank you.
Okay.
Okay. Time is done. Exact timing. Okay. Yes, Aisha. So what are your thoughts? I don't know. I was continuously talking.
Yeah, continuously you were talking. Yes. But it was to the point, and information gathering, you tried to put in all, you took the focused history and you gave justification why you wanted to know about that. That's excellent. And then coming to NYHA classification, you have beautifully mentioned about all the class 1, 2, 3, and 4. Antenatal management, yes, the safety points, everything you have added. MDT was the buzzword here. Then coming to the...
Probably I missed on the balloon valvotomy because...
I think you spoke about it.
Oh, okay, fine.
Yeah,
okay.
Yeah, you talked about it. Yeah. And then intrapartum care, yes, cut short the second stage of labor was the main thing here, and antibiotic prophylaxis. Anyway, you came back once you realized that you have forgotten about it. That was also good. And then postpartum, breastfeeding, encouragement, and contraception here, and also fluid management. I think it's well-performed task.
Perfect. Thank you, Aisha. So my point was I always forget infective endocarditis prophylaxis all the time. So the moment I came for postpartum, I remembered that it was like missed. So that's why I came back and told, sorry, I forgot about it. And contraception, I wanted to talk a bit detail, but I knew I won't be having the time. So basically, I think if you cover all these things, guys, it should be more than enough to have a clear pass. But there could be variations with that. There could be MS with metallic hat valve who's on warfarin. Then the discussion is totally different. Then you have to talk about warfarin embryopathy and shifting her from warfarin to heparin between 6 to 12 weeks and how you're going to maintain. Then the epidural analgesia, also that it changes. When do you insert? When do you remove? So, but this was the case which has been coming. So I didn't want to mix up a lot of things. So that's the reason I have done something like this. And cardiac disease has always been a hot favorite for everybody because of the obviously increased mortality. So in a nutshell, use the buzzwords MDT, and you need to talk about effect of pregnancy of the disease and effect of disease on pregnancy. It's very important that you need to speak about in any maternal medical condition. Remember, when you talk about the disease, why, when, how, who, Those questions you need to keep in mind. When she followed up, who followed up, how it is followed up, everything. So you will not miss on the things. And remember, couple of conditions like MS, you have to be on the dry side. But for aortic stenosis, it's exactly the opposite side. Okay, so you need to know how you are going to maintain the fluid balance and the complications and how you're going to avoid. So any maternal medical conditions, this would be asked like this, the information, and then probably specific. We will be looking at specific antenatal care, specific intrapartum care, and specific postpartum. So if you work around the skeleton, I think it's easier. So hopefully that would add value to your preparation. Thank you, guys. Thank you so much. Aisha, thank you so much for always helping me to do the task. Thank you.
Thank you.
Yes, guys, don't forget to like and subscribe the channel. Thank you, guys. Thank you so much.